My therapist said to record these, said it would help with the insomnia. It's, I don't know, 2 a.m., maybe later. I haven't checked. I was an ER attending for 28 years, the last 12 at Mercy General in Dayton, Level 1 Trauma Center, 60,000 visits a year. I documented everything, every patient, every procedure, every lab result. My charts were used in residency training because they were that clean. 28 years and I never missed a documentation deadline. Not once. I'm telling you this because what I'm about to describe, I charted the parts I could explain, the rest I left out. And it's the parts I left out that keep me up. February 14th, 2017. Tuesday night. I remember because someone had taped a paper heart to the ambulance bay door and the wind kept tearing it. We were 2 residents short. One had the flu. One was on a leave I wasn't supposed to ask about. Board had 14 patients when I clocked in at 7. By midnight, we'd cleared 8 and picked up 6 more. Standard volume for a Tuesday. The coffee machine in the break room had been broken since Monday, so I was drinking whatever came out of the vending machine on the 2nd floor. Tasted like someone had filtered hot water through an envelope. But it was caffeine and I needed it. By 2:30, the board was manageable. Bay 4 had a 62-year-old nursing home transfer, altered mental status, UTI sepsis, pretty clear-cut. Bay 7, a 19-year-old with a forehead lac from a bar fight, needed 6 staples and a tetanus update. Bay 11, an 18-month-old with croup. The parents were more distressed than the kid. Bread and butter. The kind of shift where you start thinking about what you'll eat when you get home. 2:47. The overhead speaker crackled. Trauma activation, ETA 8 minutes. Single vehicle MVC, I-75 northbound, unrestrained female driver. EMS was reporting GCS-3 in the field. That's the lowest score on the Glasgow Coma Scale. No eye-opening, no verbal response, no motor response. A 3 means the lights are on and nobody's home, or more accurately, the lights are off too. I set down the coffee, walked to Rhesus Bay 2. My senior resident, Dr. Kessler, was already gloving up. 2 nurses, Debbie and a travel nurse whose name I've forgotten, were setting up the rapid infuser. Standard choreography. We'd done it 1,000 times. EMS rolled in at 2:54. White female, 43 years old, driver's license said Catherine Harmon. She'd been intubated in the field, 7.5 endotracheal tube confirmed with capnography. Both arms had bilateral large-bore IVs running wide open with saline. Primary survey, airway, secured, breathing, bilateral breath sounds, vent rate 14. Circulation, BP 78/40, heart rate 132, thready radials. I lifted her eyelids. Right pupil fixed and dilated at 7 millimeters. Left pupil fixed and dilated at 7 millimeters. No corneal reflex. No gag reflex. GCS-3T. The T means intubated, so you can't assess verbal response, but it didn't matter. She wasn't there. We ran the CT at 2:55. I walked down to radiology with Kessler because I wanted to see the images come up in real time. The tech was a woman named Gail who'd been doing overnight scans at Mercy for 15 years. She didn't say anything when the images loaded. She didn't need to. Right-sided acute subdural hematoma, 2 centimeters of midline shift, diffuse axonal injury. You could see the petechial hemorrhages scattered through the white matter like someone had flicked a red pen across the scan. Bilateral uncal herniation. The brain was being crushed against the inside of her own skull. I called neurosurgery. Dr. Patel, the on-call resident, came down at 3:05. He stood in front of the monitor for maybe 30 seconds. Then he turned to me. Non-survivable. That's not a clinical term you'll find in any textbook, but every trauma surgeon knows what it means. It means the damage is beyond any intervention. No surgery, no medication, no amount of time will fix this. The only decisions left are administrative, organ procurement, family notification, the conversation nobody wants to have at 3 a.m. I went back to the workstation outside Rhesus 2, started charting. I told the intern, a second year named Marcus, who was on his emergency medicine rotation, to stay at the bedside and call me if anything changed. It was a formality. Nothing was going to change. Catherine Harmon was going to be pronounced dead within the hour, and I was going to document every clinical detail with the same precision I'd used for 28 years. That was the plan. That was always the plan. You chart the decline, you call the time, you move to the next patient. Medicine is a series of protocols, and this one was straightforward. I was wrong. Marcus paged me at 03:14. I remember the exact time because I was mid-sentence in my chart note. Patient's neurological exam consistent with, and I never finished it. The page just said, Rhesus 2, now. I walked in expecting to find a flatline, expected to call the time, sign the death certificate, and go back to my coffee. What I found was Marcus standing 3 feet from the bed, not moving, staring at the monitor like he'd forgotten how to read it. The ICP, intracranial pressure, had been 45 when we left. 45 is catastrophic. Normal is 5 to 15. At 45, the brain is being compressed so hard that blood can't perfuse the tissue. It's not compatible with survival. The monitor read 22. I thought transducer malfunction. Has to be. The bolt wasn't calibrated right, or the line had an air bubble. I checked the setup, zeroed the transducer, flushed the line. The waveform was clean. While I was flushing it, the number dropped to 16, then 12. No mannitol had been given, no hypertonic saline, no surgical intervention, no intervention of any kind. Marcus hadn't touched her. The nurses hadn't touched her. The ICP was normalizing on its own, which doesn't happen. Not with a 2-centimeter midline shift, not with diffuse axonal injury, not with bilateral uncal herniation. The herniation alone should have been progressing, not reversing. I checked her pupils. The right pupil, fixed at 7 millimeters for 27 minutes, was now 4 millimeters. I shined the pen light. It constricted. I checked the left. Same. 4 millimeters, reactive, brisk. Pupils don't do that. Once the uncus herniates and compresses the third cranial nerve, that's structural damage. It doesn't reverse without a craniotomy, and even then it takes days. Her GCS started climbing, flexion withdrawal, then localizing to pain, eye-opening to voice, GCS 8. Then her hand came up and pushed away the laryngoscope when I tried to assess gag reflex. Purposeful movement, GCS 11. By 3:20, her GCS was 14. 6 minutes earlier, she had been neurologically dead. I told myself it was equipment malfunction. I've been telling myself that for 8 years. She opened her eyes. Not the slow, unfocused opening you see when sedation wears off, or when there's a reflex response. She opened her eyes the way you open your eyes when you've been awake the whole time and you've decided to stop pretending. She looked directly at me, not at the ceiling, not at the monitor, not at Marcus, at me. And her eyes were clear, oriented, the eyes of someone who knows exactly where they are and who they're looking at. She said one word. Again, not a groan, not an expiratory vocalization, a word, clearly articulated around the endotracheal tube, which should be physically impossible. You can't speak with a 7.5 ET tube between your vocal cords. But she did, and the voice wasn't strained. It was calm, almost clinical. I opened my mouth to respond. I don't know what I was going to say. I never found out. 22. The monitor alarmed. V-fib. Ventricular fibrillation. Her heart had stopped organizing its electrical activity and was just quivering in the chest like a bag of worms. That's the textbook description. A bag of worms. I've used it in lectures. It's less useful when you're staring at the patient who just looked you in the eye and said a word. We coded her, full ACLS, epi every 3 minutes, defib at 200, then 300, then 360, amiodarone, bicarb when the pH came back at 6.9, 42 minutes. I've run hundreds of codes. Some you know in the first 5. I pushed this one to 42 because I couldn't accept that a woman who had looked at me with clear, oriented eyes 90 seconds earlier was now dead. But she was. Time of death, 3:58. February 15th, 2017. Valentine's Day. I stepped out, pulled off my gloves, washed my hands. I always wash my hands after, even though I know the gloves were intact. It's ritual, not hygiene. My phone rang at 4:15, the blood bank. Terry, the night tech, was on the line. She didn't sound confused. She sounded careful. The way people sound when they're choosing their words because the obvious ones don't fit. Dr. Callahan, we can't type her blood. I told her to run it again. I've run it 3 times, 2 different analyzers. The forward type doesn't match the reverse type. The antibody screen is pan-reactive. It's reacting to everything in the panel. I've never seen this pattern. I told her it was probably a cold agglutinin or a Bombay phenotype. Send it to the Red Cross reference lab. I already sent it, but Dr. Callahan, I've been doing this for 23 years. This isn't a Bombay phenotype. I thanked her and hung up. Went back to charting. I should have paid more attention. I should have gone home at 7. Shift change, hand off, sign out, drive home, sleep. That's the protocol. But I sat at the workstation outside Racist 2 until 8:30 staring at Catherine Harmon's chart because something was wrong with the imaging folder. I'd ordered 1 CT, the head CT at 2:55. That's what was in my note. That's what I discussed with Dr. Patel. 1 study, 1 series. Standard non-contrast head. The imaging folder showed 2 studies. The first was mine, acquired 255, standard axial cuts, the subdural and the DAI and the midline shift, everything I'd already seen. Normal. The second study, I didn't order a second study. Nobody ordered a second study. I checked the order log, nothing. I opened it anyway. It was a single image, 1 axial slice, brain parenchyma. But the geometry was wrong. The orientation wasn't standard axial. It wasn't the transverse plane you get from a CT gantry. The perspective was, it was as if the scanner had been positioned where the brainstem should be, inside the skull, looking outward through the brain tissue at the inner table of the calvarium. That's not possible. A CT scanner uses a rotating X-ray source around the patient. You can reconstruct in different planes, sagittal, coronal, 3D, but the raw acquisition is always from outside the body. No reconstruction algorithm produces this angle. It would require the radiation source to be inside the patient's cranial vault. I looked at the metadata. Acquisition time, 2:42:17. The patient arrived at 2:54. EMS was dispatched at 2:31. At 2:42, Catherine Harmon was in the back of an ambulance on I-75, 12 miles from the hospital. The first CT I ordered was 13 minutes later. The Siemens scanner in the trauma bay, I checked the log, was running a chest CT on a COPD exacerbation patient at 2:42. It physically could not have produced this image. I called radiology. Gail, the overnight tech, picked up on the second ring. I asked her about the second study in the Harmon chart. There's no second study. I only ran the one you ordered. I told her to check PACS. She checked. The image wasn't in the PACS archive. It existed only in the patient's EMR chart, uploaded directly to the imaging folder, not acquired through the scanner, not routed through the archive. Just there. Pant, I called IT. A guy named Dennis who worked the overnight infrastructure shift. He didn't ask why I was calling at 8:45 a.m. about a file upload. He just pulled the audit trail. The file was uploaded to the EMR at 2:42:7 from a workstation in Rhesus Bay 2. Rhesus Bay 2 was empty at 2:42. The patient hadn't arrived. The room was dark. The workstation requires badge access to log in. What badge was used? I asked. No badge. The system shows no login event. The upload happened from an unauthenticated session, he paused, which shouldn't be possible. The EMR requires authentication for any write action. There's no override for that. I don't know how this file got here. I thanked him, hung up, sat there for a while. 2 days later, the Red Cross Reference Lab report arrived. Most reference lab reports are 3 to 5 pages. Methodology, reagent panels, cross-match results. This one was 1 page, most of it header information. The conclusion was 1 line. Unable to classify, please confirm specimen is human. I stared at that line for a long time. I thought about the ICP normalizing with no intervention, the pupils reversing structural herniation, a GCS of 14 in a brain that CT showed was destroyed. Her eyes, clear, oriented, looking directly at me, and the word, again. Not help, not where am I. Again, like she'd done this before. I filed the incident report, documented the arrest, the resuscitation, the time of death. I did not include the ICP normalization, the pupillary reversal, the word she spoke, the blood bank findings, or the phantom CT image. Charted it as traumatic brain injury, non-survivable, expired despite resuscitative efforts, 358. I put in my retirement paperwork 3 weeks later. My department chair asked if everything was all right. I told him I was tired. That was true. I checked her chart last year. I still have EMR access. They never deactivate attending credentials, just change the password requirements every 90 days. The phantom CT image is still in the imaging folder. Metadata still reads 04217. Same impossible angle, same impossible timestamp. But now there's a 3rd study listed. I didn't open it. The acquisition time in the metadata preview was a date I recognized. It was yesterday's date. The chart for Catherine Harmon is still active in the system. She was pronounced dead on February 15, 2017. Dead patients don't have active charts. I closed the browser. I haven't logged back in. My hands are shaking. They don't do that. 28 years, 4,000 intubations. My hands don't shake.